This is the outline of my talk tonight. I'll go over the statistics from the American Cancer Society. I'll talk about how often a woman is diagnosed with breast cancer. Then I'll move on to screening. There are 3 ways to look for breast cancer in the breast, and that's mammography, breast ultrasound, and breast MRI. And then I'll talk about a very important part of breast cancer, and that's the 4 major subtypes of breast cancer, how those subtypes are determined, and how this impacts treatment. And lastly, I'll go over breast cancer surgery options. These statistics are from the American Cancer Society, and you can see along the top, nearly 2 million people in the United States will receive a new diagnosis of cancer. So about 1 million women will be diagnosed with breast cancer. And you can see breast cancer really remains the most common cancer diagnosed, accounting for about 1/3 of cancers diagnosed in women. And this is followed by lung cancer and colon cancer. At the bottom is are the statistics for death from cancer. Breast cancer is the 2nd leading cause of cancer death. And this year, approximately 43,000 women will die from breast cancer. We know that incidence of breast cancer increases with age. So increasing age increases one's risk of developing breast cancer. So a woman in her 70s has the highest risk of developing breast cancer. But overall, the lifetime risk of developing breast cancer is 12%, with 1 in 8 women in the United States being diagnosed with breast cancer. We know that there are also geographic variabilities for breast cancer. The states that are colored dark blue are the states with the highest rates of breast cancer. And you can see New York and Connecticut have one of the highest rates of breast cancer in the country. This graph is showing each line representing a cancer from a certain part of the body, and the red arrow is pointing to the light gray line that represents mortality from breast cancer. And you can see from about 1989 to 2018, there has been a 40% reduction in breast cancer mortality, most likely attributed to earlier detection and better treatment. In fact, there are over 3.8 million breast cancer survivors living in the United States. So screening is important for breast cancer early detection. Typically, breast cancer has no symptoms, and most women diagnosed with breast cancer are diagnosed on mammography. Tumors that are detected earlier tend to be smaller and more easily treated. The 3 ways that we image the breast are mammography, breast ultrasound, and breast MRI. The technology for mammography has improved. Initially, mammography used a technique using film, and then digital mammography was developed. First, 2D mammography, and now we do mammography with using 3-dimensional images. And this is known as tomosynthesis. So tomosynthesis involves taking serial images of the breast, and a woman should begin having mammograms at the age of 40. A woman, when she turns 40, should speak to her primary care doctor, her gynecologist, about starting to undergo annual mammograms. There are some women who need to start having mammograms at an earlier age. So if a woman has a first-degree relative, such as a mother or sister diagnosed with breast cancer, she should start having mammograms 10 years before the age of diagnosis. So the example on the screen is a woman who has a mother diagnosed with breast cancer at 42. That person should start having mammograms at the age of 32. The addition of breast ultrasound can improve the sensitivity of mammography, and ultrasound can be added to imaging, and a woman can undergo annual ultrasound along with her mammogram. This is a study by Dr. Brem that looked at over 15,000 women who had both mammography and ultrasound. And the study showed that the addition of ultrasound to mammography did detect more cancers in women undergoing screening. We use screening breast MRI in women with high risk of breast cancer. When a woman's lifetime risk is greater than 20%, that woman should have an annual mammogram in addition to an annual MRI. When an abnormality is detected on a mammogram, breast ultrasound, or breast MRI, and that abnormality appears suspicious or it's possibly a breast cancer, that woman typically will undergo a needle biopsy performed by a radiologist using that modality. So along the top row, you can see an abnormality on a mammogram, and the woman on the top right picture is undergoing a biopsy using a specialized mammogram machine to target the area that's abnormal. In the middle of the screen, you can see a typical appearance of a tumor or breast cancer on breast ultrasound. And to the right of that picture, you can see a woman undergoing an ultrasound biopsy. If a woman has an abnormality seen on her MRI, she may need to undergo a MRI guided biopsy. So the woman in the bottom right corner is undergoing a MRI biopsy of the breast. In the past, women diagnosed with breast cancer received similar treatment, but currently the treatment for patients diagnosed with breast cancer is very individualized. Over the next couple slides, I hope to show you a little bit of that evolution, because currently in 2021, we do provide our patients with personalized targeted therapy, and this is known as precision or personalized medicine. This is a picture of William Halsted, who is a surgeon who performed the first radical mastectomy in the United States in 1882. And you'll see that over the next 100 years, radical mastectomy was the main treatment for most women diagnosed with breast cancer. Mammography was invented in the 1930s. Also in the 1930s, we started to use radiation to treat breast cancer. And there were early developments in chemotherapy between the 1930s and the 1960s. Tamoxifen is a medication used not only to treat breast cancer, but also to prevent breast cancer. And tamoxifen received FDA approval in 1977. Surgeons began performing lumpectomies in the 1980s. A lumpectomy is a surgery which involves removal of the cancerous portion of the breast. And so you can see from the time Halsted did the first mastectomy in 1882 to when surgeons began performing lumpectomies in the 1980s, mastectomy really became the mainstay for the treatment of breast cancer. A relationship between a genetic abnormality and the development of breast cancer was discovered in the mid-90s. And throughout the last 50 years, there have been huge advances in the treatment of breast cancer with the approval of multiple medications for the treatment of breast cancer, such as anastrozole and trastuzumab. Before we talk about the different treatment options for breast cancer, I think it's really important to go over the main subtypes of breast cancer. Tumor receptors are what determines a breast cancer subtype, and after a patient undergoes a biopsy, we can determine which subtype of breast cancer a woman is diagnosed with. On the screen, you can see the four main groups of breast cancer subtypes. The four main groups are luminal A, luminal B, HER2 positive, and triple negative breast cancers. The subtypes luminal A and luminal B tend to have better prognosis, whereas the HER2 positive and the triple negative breast cancers in the yellow and the orange tend to have a worse prognosis. Approximately 75% of breast cancers diagnosed are on the left in the luminal B and luminal A and luminal B categories. And thankfully, most cancers that are diagnosed are on this end of the spectrum. Luminal A and luminal B cancers are typically treated in addition to surgery with anti-estrogen therapy and hormonal therapy. In the center are the HER2 positive cancers. And in addition to surgery, most HER2 breast cancers, unless they're small, are treated with a combination of chemotherapy and targeted HER2 therapy. And more often, treatment begins with the chemotherapy and the HER2 therapy prior to surgery. The triple negative subtypes have the worst prognosis. They're also sometimes referred to as basal-like breast cancers. This is a study just showing those 4 subtypes again with the better prognosis in the luminal A and the luminal B cancers. This is another study that looked at the survival of those 4 different subtypes. But how are the subtypes determined? So upon getting a biopsy of the breast, the cells are examined, and the tissue that's retrieved from the breast is examined through a process called IHC, which stands for immunohistochemistry. The slides that are highlighted on the left are estrogen and progesterone receptor negative. And then on the right are the cells that are estrogen and progesterone receptor positive. You can see they're staining brown. Immunohistochemistry is also the process in which we determine the HER2 status of the tumor. And now on to surgery. Some patients diagnosed with breast cancer can undergo a lumpectomy, while other women undergo a mastectomy. And the decision to undergo a partial mastectomy or a mastectomy is determined by many factors. And these factors include how much disease is in the breast, the size of the cancer relative to the size of the breast, the number of the tumors in the breast and location of the tumors, as well as other medical conditions. So on the screen is a mammogram image of ductal carcinoma in situ, DCIS, and ductal carcinoma in situ is an early form of breast cancer. On the left, you can see ductal carcinoma in situ is confined to a small area of the breast, and a woman with this type of mammogram can undergo a lumpectomy, which is removal of just part of the breast. On the right, even though it's an early cancer, the DCIS is spread out over a larger area of the breast, and a woman whose DCIS presents, such as the image on the right, may need to undergo a mastectomy. Tumor size is also an important criteria when determining if a patient can have a lumpectomy or mastectomy. And sometimes a woman has more than one area of disease in the breast or more than one tumor. Multifocal disease is 2 or more cancers in the same quadrant or location or area of the breast, whereas multicentric involves disease in another quadrant of the breast. A woman with multifocal disease can possibly undergo a lumpectomy, while a woman with multicentric disease may need to undergo a mastectomy. Women who are found to carry a gene mutation and are diagnosed with breast cancer are typically recommended to undergo a mastectomy. For women who undergo a mastectomy, some have no reconstruction, and so the chest is flat with a scar going across the chest, and some other women may undergo reconstruction. There are 2 main forms of reconstruction. The first main type of reconstruction is involves the use of an implant, and the second type of reconstruction is using one body fat from one part of the body to build a new breast, and this is called autologous tissue reconstruction. So in summary, breast cancer remains the most common cancer in women. You can see there have been promising developments in both the diagnosis and treatment of breast cancer. Women should have yearly mammograms supplemented with a yearly ultrasound if dense. Breast cancer subtype is critical in determining treatment approach, and breast cancer has evolved into individualized patient-centered treatment that is unique and specific to each woman. The next part of the webinar will be Dr. Drucker. think you're on mute.
Thank you. Hi, how is everyone? I'm going to focus on, so I'm a medical oncologist here at Greenwich and give treatments, for breast cancer. And so my talk's going to focus on how we determine what those treatments are. Again, giving attention to what Dr. Gillego spoke about, how treatment is individualized. Oh my God. So let me bring up my slides. Hold it. Oh, nope, sorry. There we go. Okay, here we go. Are they up? Hello? So this is going to explore treatment options for breast cancer. So just a quick overview of the statistics, very similar to what Dr. Gillego said, that breast cancer is very common. Of all cancers, it's about 25%, 30% in women. And again, the statistic we always get back to is 1 in 8 women will develop breast cancer in their lifetime, with that risk increasing the longer they live. The majority of breast cancers are actually not related to inherited mutations, even though we talk a lot and we screen for those. So 90% are thought to be either due to environmental issues. Most breast cancers, because of screening, are caught at an early stage when they are curative, and the majority do fall into the good prognostic range category, where they are both estrogen and progesterone positive and HER2 negative. That being said, what we consider early stage disease is anything potentially curable by surgery and various amounts of additional therapies. But 30% will recur, though that's usually more in the more advanced stage. And when we talk about what increases the risk, there are many things that increase the risk, but of course, being a woman is one of them, and living longer. And a lot of times people talk about how there's more cancer now than there used to be. And part of that is because of the improving prognosis of people. Cardiologists have done their jobs, and people are living longer, and therefore get at more risk of developing cancers in general, and for women, breast cancer in particular. So what we always like to stress, just as Dr. Gillego mentioned, is the individualized approach to breast cancer treatment. Breast cancer is not one disease, it's many. And there are various different ways you can categorize cancers. So one of the first things that decides how we're going to treat breast cancer, either before or after their surgery, is the stage. Stages 1 through 3 are considered curable. Stage 4 is not. Other factors that go into deciding how we're going to treat a patient is the age of the patient and their comorbidities. Usually younger, healthier patients are treated with more aggressively because there are more years at stake. And also we think they can handle treatments a little bit better. And then of course, some of the treatment is also determined by the unique characteristics of the tumor. There are different options available if the tumor is ER positive, such as hormone therapies. If the tumor is HER2 positive, there are therapies specifically targeted to that. And when a tumor is triple negative, we tend to focus on chemotherapy. So our treatment decisions are based on a combination of the patient and their characteristics, what the stage of the tumor is, and what the characteristics of the tumor are. So the most common early stage breast cancer are estrogen receptor positive cancers. Hormonally targeted agents are actually the most potent treatments for these cancers. And there are a variety that we can use. And again, which we pick depends on the patient. Tamoxifen came out in the 1970s. It is the oldest of the hormone treatments. And it used to be used for everyone, and now mostly used for premenopausal women. If we feel the need to be more aggressive, we will sometimes give LHRH agonists. Those work by lowering estrogen and are often given to premenopausal women as an additional sort of more aggressive way of treating them hormonally. If the tumor is small, we might go with tamoxifen only. If we think the tumor is higher risk, we will use a combination of tamoxifen and LHRH agonists. The big difference between tamoxifen and the drugs we use for postmenopausal women is tamoxifen mostly works as an estrogen blocker. Drugs that we use for menopausal women, such as aromatase inhibitors, work by lowering estrogen. So again, looking at the patient, we have to determine is the patient pre or postmenopausal, figure out what their other medical conditions are, and decide which of these endocrine therapies are best for the patient. If we think the tumor is higher risk, then we will not only use endocrine therapy, but we will use a combination of chemotherapy and endocrine therapy. Very often when patients are newly diagnosed with breast cancer, their question is, will I get chemotherapy or will I get endocrine therapy? And again, it's for an estrogen receptor positive cancer, we will always offer endocrine therapy. Endocrine therapy actually is more effective therapy with less toxicity than chemotherapy. But if we think we need to use everything in our war chest to treat the cancer, we will use both. Some of the newer advances that have occurred in making these decisions is the use of the Oncotype Dx test, which is a molecular assessment of how likely the tumor is to respond well to hormonal therapy. So when first presented with a patient who has an ER positive cancer, again, trying to figure out her risk, we will look at tumor size, we will look at lymph node involvement, the grade of the tumor, which is an assessment of how abnormal it looks under the microscope. We will look at the tumor itself and see if we see cancer cells within either lymphatic vessels or blood vessels to see, does this cancer have a chance to spread elsewhere? The larger the tumor, the greater the odds that the cancer kind of left before surgery, kind of left and spread to elsewhere in the body before surgery was done. If we see lymph node involvement, that already tells us cancer cells have left the site of the tumor and gone elsewhere in the body before surgery was accomplished. Tumor grade, which again is a sort of value judgment by the pathologist of how abnormal it looks, often correlates with how aggressive the tumor will behave and how likely it is to spread. And similarly, seeing cancer cells within blood vessels or within lymphatic vessels does suggest that there's a possibility that the cancer has spread before surgery happened, even if when the lymph nodes are assessed, they're negative. That being said, that sort of those components, tumor size, lymph node involvement, lymphovascular involvement, will tell us what is the likelihood that the cancer could have left the breast and be hiding somewhere in the body after surgery, but it doesn't necessarily tell us how likely it is that hormone therapy will kill off any cells that might be lurking. And that's what the Oncotype Dx says. And what that does, that was a test that was generated by looking at historical controls. Women who were diagnosed in the 70s and 80s who were treated with tamoxifen. That was a while ago. We know what their outcome was. Their tumors, if they were involved in clinical trials, were kept in pathology banks. And the people who devised the Oncotype Dx test actually wanted to know if the cancers of patients who they knew were cured with tamoxifen were different than the patients who weren't. So they went back to the pathology labs, looked at the molecular expression patterns of the cancers of those who were cured with hormonal therapy and those who were not, and found that there was a different pattern of protein expression in the cancers that responded well to hormonal therapy versus the cancers that did not. They then sort of made a way to assess a newly diagnosed cancer, which was it more like, the good behaviors or the bad behaviors, and then came up with the tool that we have before we start treatment to get a better sense, will this person's tumor respond well to hormonal therapy, and do we need to give them chemotherapy? And therefore, actually, the benefit of this test is that we give a lot less chemotherapy than we used to. Some of the newer developments with this test, oops, I went the wrong way, is there has been reassessment of that data. The test was originally only validated for people with small tumors and no lymph nodes. We knew there was a group that, based on the test prediction, would do very well with hormonal therapy. We knew there was a group that, based on the test's sort of score, would do very poorly if all we did was hormone therapy. So those we gave chemo to. And when the test first came out, there was this intermediate zone that we really didn't know. They were sort of on the edge, and we didn't know if giving chemotherapy to those patients would prove beneficial. More actually published, I think 2 years ago, was the result of the Taylor RX trial, which specifically looked at whether or not giving chemotherapy to women whose tumors scored in the intermediate zone had any added value. And interestingly, if you were over 50, there was no value to giving chemotherapy to people in the intermediate zone. But if you were under 50, there was a small benefit. So that allowed us to give chemotherapy to even fewer patients. More recently, the tests, the verification has been expanded to women who have involved nodes and in generally are thought to have higher risk of disease. In the past, if we saw lymph nodes involved, we were much more concerned that that a patient with involved lymph nodes was going to have their cancer come back, and we would almost knee-jerk give those patients chemotherapy. But further evaluation of patients using the Oncotype test and going back and looking at historical control shows that even women who have anywhere from 1 to 3 involved lymph nodes might do just fine with hormone therapy, provided that their cancer expresses the protein pattern that suggests that hormone therapy will work really well. So whereas in the past, any woman with lymph node involvement would have been given chemotherapy, now if their recurrence score is low, if the characteristics of their tumor suggest an excellent response to hormone therapy, we won't give them chemotherapy. And similar to the Taylor RX trial, older women are less likely to get a benefit from chemotherapy than younger women. And in that trial, they made the division: if you were already in menopause, you actually got less benefit than if you were premenopausal. And some of that is thought that the postmenopausal has less estrogen and more likely to respond to hormone manipulation. But again, the wonders of the Oncotype Dx test is it allows us or helps us prevent us from over-treating patients with chemotherapy they don't need. So this is sort of when we talk about personalized care and everyone's cancer being different, this is assessing it on a molecular level, allowing us to correctly treat patients with hormone therapy who only need hormone therapy, and reserve chemotherapy to people who are both at higher risk based on characteristics like tumor size, lymph node status, but also the molecular aspect of their tumor. So something that Dr. Gillego had talked about was the 4 types of cancer, the luminal A, the luminal B, which are ER positive, HER2 negative cancers. Presumably what the Oncotype sort of complements in that is that, luminal A are more likely to be patients treated with hormone therapy only, and that can help, is better determined by the Oncotype test. Luminal B, those patients who have ER positive, HER2 negative cancer, but are still at high risk, again, can be identified by the Oncotype test. But she had talked about how the HER2 positive cancers were poorer prognosis cancers, which historically was true, though that has changed because of new drugs that have been developed that specifically target the HER2 protein. You can see HER2 is a protein that is involved with cell growth. It is one of a family of cancers, not cancers, of proteins that help regulate cell growth. And in about a third of breast cancers, it is overexpressed. So you have more of these proteins that help cells to grow than should be there. And these cells grow very quickly and they spread very quickly. Because of this aggressive nature, when we see HER2 positive breast cancers, chemotherapy is almost always recommended, unless, of course, the patient is extremely elderly or we don't think they can tolerate chemotherapy. Historically, the reason these were thought to be such poor prognosis, high-risk cancers is even if you gave these patients chemotherapy, and if they were ER positive, even if you gave them hormonal therapy, they would come back. However, in 1998, Herceptin was FDA approved initially for the treatment of only widespread metastatic cancer. But in 2006, it was shown that if you use the Herceptin early, you could have a significant impact on these cancers, so that small cancers that don't involve lymph nodes, if you treat them with a combination of chemotherapy and Herceptin therapy, you can get cure rates of up to 95, 98%. Drug manufacturers have really focused on this really very impressive change in how we view these HER2 positive cancers and have developed additional drugs. In the past 20 years, at least 5 drugs have come out, possibly more, to treat HER2 positive disease. Many are still only used in the metastatic setting, but what have been added to the early setting where we're looking to cure patients. There is now another HER2 targeted drug called Perjeta, which came out in 2017. And then there's a third drug, Kadcyla, first came out in 2013 for the treatment of metastatic disease, but in 2019 was shown to improve cure rates for patients who had, if they were treated first with Herceptin and at the time of surgery were found to have persistent disease. So something that has changed also how we incorporate chemotherapy and surgery for early stage HER2 positive disease. Historically, we would always give chemotherapy afterwards, but now because of the studies that have shown that if you can't make all the cancer go away with treatment before surgery, changing therapy to Kadcyla also improves cure rates. This has really changed when we introduce chemotherapy. Now, sometimes, especially for HER2 positive disease, we'll do it before surgery rather than after. And then lastly, we get to triple negative disease, which is very high risk, partially because we don't have targets. Hormone therapy with either tamoxifen or aromatase inhibitors won't work because there's no estrogen receptor controlling cancer growth. HER2 targeting agents won't work because the HER2 protein is not overexpressed, and chemotherapy is the only option. Things that have, new approaches that have come in the past few years and things that are currently under study are the ideas of adding yet another drug. Often we will treat triple negative disease with a combination of 3 different chemotherapy agents. And what's being actively looked at now is the benefit of adding a 4th. And perhaps one of the more exciting changes that has also occurred with triple negative disease is the addition of immunotherapy, trying to get the immune system involved in trying to kill cancer cells in addition to the chemotherapy. And just this year, the FDA approved an immunotherapy drug for high risk but curable triple negative disease in combination with chemotherapy, which has again been shown to improve cure rates. Here at Greenwich, we are continuing to participate in clinical trials, hoping again to add more options to our patients who are diagnosed with breast cancer. One trial is the DARE trial, which is looking at women who have potentially curable disease, but high risk because the tumors were either large or involved a lot of lymph nodes, and looking for evidence of circulating tumor cells in the blood. If those are found, The clinical trial will randomize them to going to different hormone therapies to treat their cancer in combination with some oral drugs that can make hormone therapies more effective versus continuing as we normally would with just continuing on hormone therapy. And this is a trial to look at, one, are there better hormone combinations for women with estrogen receptor positive disease? And is this tool looking at circulating cancer cells in the blood an effective tool to guide our treatments? We also have some studies for triple negative disease, one referring to regarding adding a fourth drug to chemotherapy, where standard of care is using 3 drugs, and checking to see if adding a fourth will have benefit. And then we have another study here, again, looking at for patients who don't get immunotherapy up front, if they still have disease at the time of surgery, will adding immune therapy help? So again, the major points of what I'm trying to say here tonight is that breast cancer is not one disease, it is many, and it's very important to personalize treatment to both the patient who has the cancer and the characteristics of their tumor. And then things are improving all the time. So as I always like to look to the future and participate in clinical trials, it's the way we get answers and better treatments. And thank you for your time.
Thank you, Dr. Drucker. Now for Dr. Allison Campbell from Radiation Oncology.
Okay, just trying to share my screen here. Can you guys see my slides? Okay, great. So thank you so much for inviting me to be part of this panel. My name is Allison Campbell and I'm a radiation oncologist here. So Dr. Gillego and Dr. Drucker have given a great overview into sort of the statistics of breast cancer and how important individualized treatment is. So I'm going to shift gears a little bit and talk about radiation, because a lot of times people haven't really encountered radiation in sort of their daily life. So radiation is a part of cancer care in that it's very good at killing cancer cells, but not healthy cells. So what we say is that radiation selectively kills cancer cells. So we use beams of high energy particles. Usually these are photons. Sometimes these can be electrons or protons. And we target the breast. And these high energy particles damage the DNA in the cells that they fall on. But normal healthy cells are able to repair their DNA, while cancer cells are dividing very quickly and cannot repair their DNA. And so when they go and try to divide, they actually die. And so that's how radiation kills cancer cells selectively. Generally speaking, when we are using radiation, it's coming in after surgery. But as Dr. Gillego and Dr. Drucker said, every patient's journey through breast cancer is different and depends on their stage and their hormone receptor status. But a lot of times people ask me, if margins are negative after surgery, why come in with radiation and give that as another treatment when everything that we can see has been gotten out? But we know that occasionally, even single cells that are cancerous or precancerous that are left behind can go on to divide and cause the tumor to come back. So radiation can kill these cells and reduce the risk of cancer recurring. And to put some numbers to this, so in older clinical trials, we know from many, many studies that generally speaking, the benefit of radiation is to reduce the risk of local recurrence by approximately 50% in early stage breast cancer for patients who've had a lumpectomy. And that this reduction in local recurrence actually also translates to a benefit in overall survival. So the numbers that have come out of these really big studies are for every 4 recurrences prevented, we save 1 life. For late stage breast cancer, the numbers are a little different. It's usually a greater than 50% benefit, but this depends a lot on some of the characteristics of the tumor and whether there are any lymph nodes involved. But radiation can also confer an overall survival benefit in advanced stage breast cancer. So how do we give radiation if it is part of a patient's treatment strategy? So we actually take great care when we plan the radiation. So I'm going to talk through exactly what we do. And then we use a machine called a linear accelerator to actually deliver radiation. And it's a treatment that you get every day for a period of weeks, depending, again, on your own personal stage and risk factors that you have. So we'll talk about all of this in detail. So the first thing we do when we plan radiation is we do a simulation session or a planning session. And we bring the patient in and have them lie flat on their back, and they go through a CAT scanner. And that's what you're looking at here. This is a picture of a woman who is lying, her feet are toward us. So the right-hand side of the screen is the left-hand side of her body. The two sort of dark ovals in the middle are the lungs. And then in the center of that is the heart. And the breast tissue is over to the side. So the first thing that I do after we get this kind of scan is I actually go through and map out both normal structures and also the area that we want to target. So here you can see the heart is circled in red, the lungs are circled in green. And then on the left there, you might think that that looks potentially like a tumor, but actually this is for a patient who's already had surgery. So what you can see there outlined in the pink is a very small fluid collection where the tumor used to be. So a lot of times we can see surgical changes that we then go through and we map and we put a margin on to make sure that when we're treating the breast, we're covering that surgical area very well. So then once we have our mapping done, we design our radiation fields. And this is all done by computer. Right here, you can see several different representations of how we arrange our beams. But generally speaking, here they're kind of shown as flashlights. Even though in real life, the beams are invisible. You can see that one beam comes in on the top left here, sort of from the middle of the chest pointing toward the armpit. On the other below, right below here, you can see we have our other beam coming in from sort of the back into the side. So what you get if you look on the top right here is you get this targeting of all of the breast tissue with a tiny little slice of the lung because of the curvature of the chest wall. And what you can see down here in the bottom right-hand corner is an actual representation of those beams. So you can see that the radiation is coming in from two sides, and then we're getting excellent coverage of our surgical bed. So a lot of mathematics goes into the planning of all of this. But then, one thing that we do when we're putting all of this together is not only are we making sure that we're targeting the breast tissue and the surgical bed, but we want to do everything that we can to protect the normal structures from getting any significant radiation. So for right-sided cases, this is more straightforward, but on the left side, the heart is very close right underneath the breast. So we have two different strategies that we can use to protect the heart. The first strategy is to have the patient actually lie on their stomach, and we have a special table with a CAT scanner so the breast can actually hang down away from the body. So that's what you're looking at here. This is a person who's lying on their stomach. This is the heart here. And then in blue is the breast tissue, and yellow is the border of the radiation field. So you can see that we're able to treat the breast, which is hanging down and away, without treating the heart. Sometimes this technique isn't the right one to choose. Sometimes people can't lie on their stomach, and sometimes we really need to treat this area that's lateral to the breast, sort of in the armpit where the lymph nodes are. And this technique doesn't give us great coverage for that. So my favorite way to protect the heart is actually to use a breath holding technique. So when you take a deep breath, your lungs inflate and it pushes your heart down and away from your chest wall. And we're actually able to come in with radiation beams between the heart and the chest wall. So we're blocking the heart from getting any radiation while still giving radiation to the breast. And this also gives us really good coverage of those lymph node regions under the arm. So we have a lot of very special monitoring systems that allow us to see how the chest rises and falls in real time while people are taking and holding a breath. So when we ask patients to hold a breath, they're only holding it for about 20 seconds. And we're able to see that they're holding the correct depth of breath by monitoring the surface of their body. If someone were to sneeze or have the hiccups or, anything that got in the way of that, our machines would shut off automatically because we tell them exactly where the chest wall should be to get the beam of radiation to come in safely, keeping the heart blocked. Once we've done our planning, then we bring the patient in for treatment. This is the treatment machine that we have. It's called a linear accelerator, and x-rays come out of the circular part at the top. The patient lies on the table and the machine moves around them to deliver the radiation. A lot of patients want to know how we know that we're right on target. And we have multiple mechanisms to do this. So at our planning session, we'll make markings on the skin. And then when we bring the patients back for their actual treatment, we use those markings to set up to make sure that we're in the right place. We have a laser alignment system, and we use those lasers to line up right at the center of the markings that we make at our planning scan. But we also do other things too. We have X-ray verification of internal anatomy so that we know that even when we're right on the skin marks, we also know that the bones are lining up because we do an X-ray before the start of our first treatment. And then for almost all patients, we use surface monitoring of the skin so we can see if there's any changes in how they are setting up day to day, how the breast is falling, if there's any swelling. All of these things can be monitored by our systems. So we know every time we're giving radiation that we're really right on target down to the millimeter level. And then finally, as Dr. Drucker and Dr. Gillego explained, everybody's breast cancer journey is different depending on their stage and their hormone receptor status and their age and their general health. So we don't give the same radiation regimen for every woman that we see. We have 3 major regimens that we choose from. The first is a standard fractionation regimen. So this is an older regimen, but we still use this for our high-risk patients or for patients that have had a mastectomy or who have cancer in lymph nodes, where we need to set up special fields specifically targeting those nodes. So for these patients, it's 5 weeks of radiation to the whole breast or to the whole chest wall, followed by 5 treatments where we boost the surgical bed. For most early stage or lower risk breast cancer patients, we use what we call a Hypo fractionated regimen, which just means it's a fewer number of fractions. So in that case, it's treatment for 15 treatments or 3 weeks to the whole breast, followed by 4 treatments to the surgical bed. And then there's a special category of women who have lower risk cancer and who are over the age of 70, where we can use a special regimen called the FAST regimen. And this is 5 treatments total, given 1 treatment per week without a boost. So again, this is a special regimen for very low risk cases. But those are our general paradigms. So to kind of tie everything together, as Dr. Gillego and Dr. Drucker have said, and as I've tried to emphasize as well, every patient that comes in gets sort of a custom path through their treatment based on everything that we know about the risk factors that they have. Generally speaking, for early stage disease, patients will get surgery. maybe chemotherapy if their Oncotype test, as Dr. Drucker was talking about, returns as high risk, followed by radiation, and then hormonal therapy if they have hormone positive markers. For a disease that's more advanced, when the tumor is very large initially, a lot of patients may get chemotherapy first, followed by surgery, and then radiation therapy and additional systemic therapy. I think ultimately the message is that all of us work together. Dr. Gillego and I have local therapies. So surgery and radiation specifically target the tumor where it is and the surrounding breast tissue, while Dr. Drucker specializes in systemic therapies that work throughout the whole body. And so these kind of all go hand in hand to give people the best possible care. And that is the end of my talk. So I think it's time for questions, which I think Dr. Gillego is going to moderate for us.
I'd like to thank the speakers, but most importantly, I'd like to thank all the people who joined us tonight for the webinar. Thank you for taking the time to watch the talks. And if you have any questions, you can type it into the question and answer section. I don't see any questions right now. I guess Beverly, I'll ask a question.
Okay.
Some women would like to know what they can do to decrease their risk of getting breast cancer. So in a woman who doesn't have breast cancer, what are some of the things that she can do to decrease her risk of developing the disease?
So some of the things that a patient can do, there have been studies that have shown that women who exercise regularly have lower rates of breast cancer, which is also just good for your heart health and general overall health. You know, sort of a diet low in fats. Again, all the normal things we think are healthy. You know, there's a slight increased risk with smoking. There's potentially a slight increased risk with alcohol use. And so, you know, lifestyle, everything in moderation, sort of being health conscious. I sometimes hate to stress that because I don't like to blame people for their cancer. So I have people who are vegans and exercise all the time and can still get breast cancer. So I always hate to, like, I don't want to think that you did something to get breast cancer. Being a woman puts you at risk for breast cancer, but certainly, you know, to be mindful of, you know, our weights, what we eat, and what sort of, I hate to say, common sense approach to keeping healthy. The other thing that I like to stress is, you know, sometimes, you know, bad stuff happens. People are diagnosed with cancer. But early detection is really key. So I spent my whole talk focusing on early stage breast cancers. It is so important to go for your mammograms because when we catch breast cancer early, when we catch it when it's small, that's when we can cure it. And that the earlier we catch it, the less chance that I have to do something like give chemotherapy. And something I didn't stress when going through the Oncotype is, you know, originally in the Oncotype, this ability to better define who doesn't need to get chemotherapy was only for patients with lymph node negative disease. It has now been expanded to include more groups, but for patients who, you know, are sort of not mindful of going for mammograms, if the cancer is there and not detected early, we feel forced that the risk is higher and we have to give chemo. So certainly exercise, quote, eat right, everything in moderation, you know, try to avoid fats, eat more complex carbs and less simple carbs, but also, I can't stress enough, go for your mammograms.
Thank you. And I have a question for Dr. Campbell. If you could go over, women who undergo a lumpectomy, the surgical removal of the cancerous portion of the breast, are typically recommended to undergo radiation. But what are the indications in which a woman has a mastectomy, but then is recommended to have radiation after a mastectomy?
Yeah, so there's some areas of that are very straightforward and some that are more controversial. So after a mastectomy, if there is lymph nodes that are involved, then depending on the number of nodes, the strength of the recommendation goes up. So the more lymph nodes that you have involved, the stronger the recommendation is for radiation after mastectomy. And we treat the lymph node region and the chest wall. In addition, even if you have only 1 to 3 positive nodes, there's still been shown to be a benefit of radiation. So right now, the NCCN current guidelines recommend that even in the setting of just 1 to 3 nodes positive with a dissection, that women still consider, at least come see a radiation oncologist to talk about post-mastectomy radiation. Other things that can push us in the direction of talking about radiation are large tumors. So tumors that involve the chest wall or the skin, or where there's lymphovascular invasion. And then always for young women with triple negative cancer, most of the time they've received chemotherapy up front. And there are some ongoing clinical trials looking at whether we could maybe omit radiation for women who've had a complete response to that chemotherapy up front, followed by surgery. But even in those cases currently, before those clinical trials result back, the standard of care is still to offer radiation based on the initial staging of the cancer.
Thank you. So a question just came in, Dr. Campbell. If you can go over the side effects during radiation for a patient who's had a lumpectomy, has early stage disease, are you able to say what kind of treatment she would get and the most common side effects she would experience?
Yeah, so stage 1 disease, it's, sorry, did you say hormone receptor negative?
Yes, hormone receptor negative, HER2 positive.
Okay, so I think also we can loop Dr. Drucker in on this question too, because with HER2 positivity, that's definitely something that needs to be addressed with systemic therapy. But to start with the radiation side of things, so if there's no lymph node involvement, then you would be eligible for this 3 weeks course with a boost to the surgical bed for a total of 19 treatments. And the side effects for this treatment course are, generally speaking, relatively mild. So the things that I most of the time see are fatigue and skin irritation. And the skin irritation can range from just a mild pinkness of the skin with maybe some dry peeling, like a mild sunburn, mild to moderate sunburn, all the way to, in extreme cases, and this I don't expect, but some blistering of the skin, especially sort of along the bra line underneath the breast. I would say the vast majority of patients, though, go through with just some pinkness and some dry peeling like a sunburn. And that usually within 10 days after radiation, that's really started to heal up. And by 1 month, the side effects are much less. Other things that are rare with radiation, but that I always talk to patients about are there's a very tiny risk, less than 1%, that radiation can cause inflammation of the lungs, something called radiation pneumonitis. And that's something that we have to treat with steroids to cool down inflammation if it happens. So those are the main side effects. Usually that 3-week course is tolerated very well by patients. And then I'll let Dr. Drucker talk a little bit about the HER2 positive side of things.
So typically with an ER negative HER2 positive cancer, once you recover from surgery, we would do chemotherapy prior to receiving radiation therapy. We keep those separate because chemotherapy can interact with radiation and make it more potent and therefore have more side effects than we anticipate. So we usually do the chemotherapy first. And for a small tumor with no lymph nodes, we've been able to cut back on what we give. The most important part of the therapy there is the HER2 targeting agents. So a very common regimen for a tumor such as yours would be 12 weeks of weekly chemotherapy, followed then by a full year of Herceptin therapy. And I always like to distinguish Herceptin-based therapy or HER2-targeted therapies from chemotherapy. People often hear, oh my God, a year of therapy. Oh my God. And the Herceptin is not chemotherapy. The only commonality is you have to come into the office and get it intravenously. However, whereas chemo, we always worry about hair loss. There is no hair loss with Herceptin, minimal fatigue, no nausea. And proof of that, you can start the radiation while you're receiving the Herceptin, because again, it's not going to have the side effects we associate with chemotherapy. And then this is a commonality throughout all of our treatment plans for breast cancer. I don't know why it often works out like this, but surgery aside, because you're asleep for that, when we give our therapies after surgery, we often start with the worst first. So, and I have to say, even though it is my job to make the chemotherapy tolerable, the chemotherapy is certainly worse than the radiation, without question. So you get your chemo with the Herceptin, and then you can take a deep breath when it's done, because the next phase, the radiation is nothing for anyone who's had chemotherapy. We actually do give you a break to recover. So usually, if you haven't already met Dr. Campbell, we set you up to meet her like your last week or two of chemotherapy. You then get about 3 to 4 weeks to recover from chemotherapy before you go on to the radiation. But again, since the Herceptin is really not like chemotherapy, that continues throughout. And then you just get very used to our site.
Thank you. Well, it's past the hour, so I think that's the end of the webinar. Thank you again to the panelists, and thank you especially to all of the participants who joined us tonight. Thank you.
Thank you.
Good night.